Thank you for being here. And this is a very important subject matter this year, perhaps one of the most important ones. I see Benoit laughing, but when he'll be a patient, we'll see what he thinks about it. So, I thought it was great to have 15 minutes of criticism, 15 minutes of positive comments, and 15 minutes of conclusions. But no, we don't have that much time. So let's move on directly to the positive aspects. Positive aspects. Health is great. We have a sanitary democracy. That's great. And now the place of the patient in the system is a well-recognized place within and throughout all instances and by all actors in the health systems. Now, in terms of criticism, we are not being listened to. When we speak with ARS, we can hardly speak about the problems that we would like to raise. And we think that health representatives should be included in a number of committees. And for the time being, we have many blockages with this respect. Now, I spoke a lot already, so I'd like to show you a few slides from the CHAM Ipsos survey to show you what's the perception of patients when you ask them if they want to take part to boards. So any types of boards. 66% of patients say they agree to take part to boards, so be part of governance. 15% say no, perhaps yellow vests, and 19% of patients don't know. So about 20% of people don't understand anything about the health system, which is not a surprise. Now, if you ask them if they would accept to be part of a board, for 63% of people, they say that they would accept to be part of the board of health establishments, and 58% say they would agree to be part of the board of an agency. So, what propositions could we make to improve governance? And instead of having a consultative role, how could you play a more active part in the governance of structures, companies, or in governing access to care, and in such a way that it would be recognized by all actors of the health system? Well, we are in 2019. Sanitary democracy has been put in place in 2002. Since 2016, it's been highly promoted. Being present and represented, that's fine. Having some legitimacy, that's quite different. This cannot be imposed. And for people who are in a situation like mine, representing users in a region, in the CPTS, it is a full-time job. So I have about 35 hours per week of volunteering, and it's not always easy to do all that. It needs some training, and we have to relinquish the candor of the RU, representative of users. And in this approach, we have to reinvent the wheel. It takes a lot of work to comprehend mechanisms and policies.
So if 66% of French people want to be on a board of a healthcare center or hospital, It's a bit like having tokens for being present. Now, unfortunately, it's not the case. We're not here to earn money. We're here to get things moving. And the method that we're using at the moment, as far as I'm concerned, is based on consensus. We look at everything. We look at everybody's different points of view. We get people to talk. And then we remind them that we're fighting for the person who is concerned. In other words, the most vulnerable person. It's not because we don't have the necessary technical skills that we aren't able to judge. Evelyne POUPET, as somebody in charge of a hospital, the way you manage relations, the representatives of users and the different structures that are part of the health democracy, how do you see them and what proposals can you put forward in order to have patients, say, being integrated more in decisions taken by the hospital? Now, effectively, as the head of a hospital, I'm convinced that that place is very important. However, I'm not going to go through everything that you've said. This is something that we see in the field. We see it on a day-to-day basis. We see it in the authorities, health authorities, time and volunteer work. Now, what I think is that when users are involved, they're involved because the texts say they have to be involved. It's almost imposed, if you like. Whatever the case, from where we are, we're thinking about how to associate them even further beyond what the texts say, including training, because I put forward an idea to integrate intergovernance authorities, because there are new texts, to integrate users at that level, because, how can to talk about healthcare in the future, to talk about how to anticipate, how to be proactive. This starts from teaching, the training of our health professionals. So this is the work that we're doing locally, at least, to try and integrate patients, users, even further in the process. Frédéric, we've seen the proposals made by patients and those made by hospitals. We know that in the representative authorities of medication, there is patient involvement. Can we do better? Should we do more? How should we be going about things? I think we've got to start with what Catherine was saying this morning. We're not working for patients. We should be working with patients. This is the real change that we have to move ahead with. And I think the real problem is, well, to get the patients involved, and this is what Eric was saying, to get them involved, we mustn't ask, it's not just by being positive. We've got to respond to a need. Everybody has a need on whatever side of the fence they are. A medication company is in charge of developing new medication, and it has to make sure that it benefits patients in the best possible way. We were talking about quality, statistically measured quality earlier on. So that's the first thing in terms of positive thinking. And when it comes to patients' associations, we know that there are expectations in terms of training. There are expectations in terms of transparency and also in terms of support and partnership. They have expectations when it comes to research in rare diseases, for example. And also with respect to medication companies, drug companies, I see things in two different ways. There are two ways to approach this subject. First of all, we can look at the life cycle of medication, of drugs. Patients must be integrated in our thinking when we are in the proof of concept stage, when we are developing the drug, until we talk about access, and then we have to measure and we are in real life, and, even when the medication has become generic, so that we have a certain number of examples. In my company, we have a partnership, and we have patients who are part of drawing up protocols and consents. We include them very early on in the process of development. This is obviously legitimate. Now, in drug companies, we've worked a lot on this subject. As part of a pediatric council, for example, we worked on this subject collaboratively with patients' associations, with healthcare professionals, to identify first and foremost the needs. And once these needs were identified, they were based on three things: quality of treatment, research targeting, especially for pediatrics, and also support for families. So once we'd identified that, because we'd identified the need collaboratively together, once that had been done, we asked the question of financing. So via the foundation, we made sure that a certain number of the projects could be financed so that we could go further. But I think that the most important point here is to really identify the needs that we have, whoever we may be, because integrating patients, it's about working with patients, not for patients.
Question complémentaire sur une.
An additional question: if you take the LEM group,
Est-ce que tu es content?
are you happy with the way things work and the participatory work with the user associations? A lot has been done. For example, for the Rare Disease Committee, Christian will be able to talk about this. He's been involved in it very passionately. Though it was already a platform for exchange, for targeting, for earmarking, and we have a certain number of these platforms. Now, I think we can go further. I'm not sure that the solution would be to invite patients to sit on boards of directors. We could try. I don't think that's the best idea. We have to look at the platform and look at the needs. But we started this thinking, when schools went back. The idea was to say, how do we integrate patients in governance, and why? Because today, when we think about the next 10 years, we know quite well that the type of treatments that we're developing, that are in the pipeline, will change the healthcare path and the path followed by drugs. So it's important that we need to think about that now. And it's not by integrating patients, say, oh, we'd be good to put patients on the board of directors, it would look nice in a press article. No, the idea is how to integrate the patient and the result of that. So we are thinking about this. And I think between now and the end of the year, we'll be able to be a bit more concrete in the way we want to integrate patients as part of that thinking, because it is a strategic question. Eric, given what he's just said, Frédéric, what's your position? And what about, with respect to drug companies, we've already got structures like Philips involved in healthcare. We've got AXA involved. We've got a certain number of industrial players who really want to be involved in the healthcare system and provide services and products in the health sector. So that change, such as it is seen by drug companies, are you happy with it? Are there things that you would like to change or add? Well, yes, I'm quite happy with that. Why would I be against that? However, what is important is that when you ask people to participate, we need to be able to identify and collect in the needs. Let me take a very simple example. We're very happy. I'm somebody who was saved from a disease, hepatitis. I don't know if there are any lab representatives here. There was a specific lab that provided a medication. Now, for some of us, we didn't really understand what the social side effects would be. So from one day to the next, so we'd all participated in the approach, the medico-social approach, the healthcare approach. But when we came to eradicating the pathology by the MDPH, that start to say, well, you're no longer part of that box, and some people had hardly ever worked, and they found themselves in a situation, they were faced an obligation to find a professional activity. And that's not because of the companies, no. But I think that it's something that really needs to be talked about well ahead of time. And it's increasingly the case. I'm a person, I'm a survivor, I've adapted, but I always think about the people who can't adapt, who haven't been able to adapt. And the system, well, let's talk about innovation and all that surrounds innovation. The idea of integrating patients in thinking is to get society to change its borders. When you talk about AXA being present, I'm sorry, ladies and gentlemen, insurance companies make me afraid. They haven't changed with the change in terms of chronic disease management. And that's why patients are necessary. They have to be present in all fields, because there's also this approach that has to be wide when it comes to healthcare. So this is a problem that was diagnosed in 1996, and when triple therapy was emerged, there was the Minister of Health who said something. Now, what are we going to do with our lives now that we've got these treatments, and what are the medical and social impacts going to be? So I think we're looking at the failure of the system. There are too many separations, too many silos, medical, social, and healthcare. There's an essential challenge. We're talking about patients, but we need to take into account the patient's environments as well. We talk about proximology, which is a strange term, but it means what it means. In other words, it's not the patient as somebody who is suffering from a disease. We can talk about users as well, and they're not the same thing. And when we talk about the patient, we need to consider the patient with the patient's ecosystem. And this is what we're doing increasingly in all of our companies, generally speaking. So a question, Evelyne, about the organization of healthcare. There's something exciting happening at the moment. We're at the start of a revolution in terms of the organization of primary care with the professional organizations, local organizations. How, in the governance of these structures, how do you see the role of the patient? Because in the future, to a certain extent, when healthcare professionals like Jean-Paul or Patrick in the first row, or Luc, I've got to be careful with the CSMF. If I separate them, people will not be happy at all. There'll be a clash. So those three people over there, when they want to do CPTS, they're going to have to consult the local officials, patients' associations, the regional health authority. How do you help with dialogue? With the presence of patients inside the CPTS, this seems essential, all the more so that if you take an area with hospitals, the patient should be at the heart of concerns. We talked about quality. So we need to work with the patient. We can't just have indicators locally or based on the hospital. We need to take into account the whole path followed by the patient. So the patient is an essential element. And I'm thinking, as somebody who's in charge of a public health hospital, I believe in managing the healthcare path. We need to have patients involved. They're going to be the first vectors of communication. If we can, if there are functional problems, operational problems, if there are accidents, the patients still have a long way to go, in fact, to be proactive and to be involved in promotional activities that need to be developed. Without the patient, we can't, as has been said, we can't, do everything for the patient. This is a culture that we need to focus on. We need to do it with and for the patient. So patients' associations in the future, will they be promoting CPTS? Or, where will they be in the future? I think it's Gérard Raymond who should be answering that question rather than myself. So if the associations are approved, yes, why not? Now, with respect to me, I consider myself as a mediator because often things are not going very well between these gentlemen. Not everybody agrees with everybody else. Professionals don't always agree with each other. So first of all, you've got to get people to agree, and then you've got to make sure that things are changed, and you've got to point to what's not working. And this means that you've got to have feedback systems. You've got to listen to what's happening in the field. You've got to listen to what Mr. Basculier was saying earlier on. You've got to listen to the population. I'm not an elected official, but you've got to listen to the population, and you've got to be a sounding board of all of this, without, of course, taking over from what the professionals say, talking on their behalf. It's very important to be diplomatic, and that's not always the case. Sometimes I'm told that I'm rather vehement, but it can be useful. Anyway, it takes time. You've got to use the right terms, the right words, so that people do listen to you. Frédéric, to come back to this organization of healthcare, you've got a new molecule, a new way of taking into account certain conditions, carticelle, treatment for different rare diseases. There are many paradigms that are shifting in terms of drugs and the traditional drug development cycle. Do you think you're going to be consulting or co-building healthcare paths in the future based on management that nobody really knows yet? When we talk about carticelle, we don't know. Many people don't really know what that means, but it does provide us with hope. Are you going to be co-building the path with patients, or there will be a kind of a parallel approach? The example of carticelle, well, there are two questions. There's the healthcare path, but it's not necessarily the patient's healthcare path that's the most complicated. It's the drug path that is more complicated. There's no point looking at carticelles. When we talk about therapies for cancer, for example, without us seeing it, we were asked questions that we never heard. The treatment against cancer via oral therapy, allowing patients to take their treatment at home. So that's great. Patients stay at home. This means that their quality of life is better. This means that their environment is better. It's much better for the patient to be at home. However, this means that all of a sudden, on their shoulders, they have a new responsibility, the patients. They now found themselves being able to take decisions. I'm going to see my family tomorrow. Shall I take my treatment today when tomorrow I won't be feeling very well? Perhaps the day after, I need to go to such and such an event, and I'm fed up of this treatment. I remember a report that we worked on last year, a life based on prescriptions. It's very striking. And one of the patients treated for cancer said, well, at the end of the day, who does my life belong to? And this really did strike me, because that's where the challenge is. When you make the patient responsible, you've got to go right through to the end. You've got to make sure that the patient is able to really manage their treatment properly, that they are informed, that they are monitored. We've talked about artificial intelligence all day long. That's great, but we can't just send the patient home and say, OK, that's all well and good. Off you go home. You'll feel a lot better at home. So there's that reasoning that exists. It's not new, and that's why I'd like to come back to our basic job. Our job is to develop and make sure that the treatment is followed and taken in the best possible conditions so that it's efficacious. And this has to integrate patients. I have another theme, another question. We've talked about quality assessments. The High Health Authority in France recognizes that the quality of life of patients is something that should be at the core of any assessment, based on assessment criteria when it comes to healthcare products, but not just healthcare products, also acts, services provided by hospitals and healthcare centers. How can patients really have an impact on that assessment? I'm not just talking about the High Health Authority in France. There are other structures, other organizations where the assessment can be carried out, agencies, administrative departments, hospitals, other professional centers, in the relationship between professionals and patients. What proposal can you make in order to improve this assessment and make sure that we can move forward with concrete ideas?
I'll start, maybe. Well, as concerns us, we integrate the patient in our evaluation groups when we don't wait for the assessments that are imposed on us. It's regular. If we have these feedback committees that we need to participate in, we also integrate patient representatives in these and user representatives in these committees. We try to integrate to the maximum the user representatives. Today, this is through the CDU, which is the Users Commission of the establishment, and patients can participate into our internal assessment groups. I have 2 examples. And 3 minutes, yes. It'll be quick. Vaccination against the flu. Last year, 68% of the vulnerable populations were vaccinated, and currently the assessment, 33% of the staff were vaccinated. So these are possible transmission vectors of a problem within the establishment. We have been ringing the alarm bells. It doesn't work. What's going to happen? Well, we're in terms of our board of directors and the different user committees, we're going to send in reports that will be sent systematically to the French Health Authority, because at a given moment we're going to have to make a practical decision. We cannot ask people to be empowered and people to take vaccinations if we're not vaccinating our staff. Now, I was hospitalized. This is a second example. I was hospitalized 2 weeks ago, and I received some equipment before the operation. And I discovered a proposal to give me back my dignity as a patient on the stretcher. So yes, that little blue nightgown, if you will, and there's a sort of a net underwear. And I wonder which user validated this underwear. I mean, it's really, really embarrassing. So where are we? It's not possible. We were not represented because this thing, in a sort of a fish scale net, I refused to wear it, and this posed problems. So our dignity is not respected sometimes. And how can we feed this back? How can we report this? If you're not a complainer, people don't take this into account. What about the assessment? Well, Frédéric, that's interesting because I think in a certain sense administrations have anticipated this approach, whether it's the HAS, the NSN, of course, the Transparency Committee as well. They already integrated patients in their debates. But have we really identified the need, and was it just a pretext? Were the patients there? Did they have the necessary competence? Were the patient representatives, did they have the mandate and the responsibility? I'm not sure. We can debate this. If we look at we need to start with healthcare democracy. We hear this term a lot now, but we need, yes, the idea is to accelerate access to innovation. And the third topic was to have a proportionate regulation. So we'll see what comes out of this for these new French CEPS programs. But, well, the CEPS should be able to include patients, but we need to know what missions and what resource. Well, there's a president, the chairman of the CEPS could be a patient. Why not? Why not? Well, no comment. Well, thank you very much.